Well, thank you very much. Welcome back from lunch. I think some people saw what was outside and decided that that was a better option, perhaps, but I am delighted to be here. It was really exciting for me to hear the work this morning. I think I'm going to be able to skip through a fair amount of my slides because we have all come to the same conclusions about dissemination. And so it also felt really wonderful to be in a room with people whose heads were nodding, and I don't often sit with people who think about dissemination. So thank you very much. Healthy Steps for Young Children was initiated by the Commonwealth Fund in 1995. Their goal was to infuse child development and family support into primary care pediatrics. In the ensuing years, we've increased that notion of what we were infusing into primary care to also think about infant mental health, which was not something that was initially part of the Commonwealth Fund. We are an evidence-based model as designated by SAMHSA and McVie, and we focus on social emotional well-being in young children and the prevention of mental health concerns. So we really tried to infuse trauma-informed care as well as infant mental health into primary care. And I was very aware this morning of thinking about, I see Healthy Steps as a great platform for pediatrics to begin to address the issues that they're seeing in their population. And yet I realized, thank you, Lauren, that we're adding on things to the original model as it was originally researched that we have not looked at since then. So the notion of trauma-informed care is not something that we have really done a good evaluation on. So I wanted to say that up front. So, we started based on developmental theory. We were really developing things just as the brain research was becoming part of the language of early childhood education. And as I tried to teach many of my pediatric colleagues, we are a relationship-based model of care. We're crosswalked with Bright Futures. We worked very closely with the AAP. We do use a strengthening families focus, and currently really adhere to the NICHQ guidelines for patient-centered medical homes. And that's really where I see Healthy Steps going in the future, is that it is a model of patient-centered medical homes for primary care pediatrics. As I said, we're now looking at not only trauma-informed care, but we have also collaborated on the Fussy Baby approach coming out of Erickson Institute, and we have just trained all the Healthy Steps specialists around the country in Fussy Baby. And we do provide technical assistance so that sites can begin to work on CQI. These are the assumptions of Healthy Steps, and I think they are quite different from other points of entry into the system, because really primary care pediatrics is a powerful point of entry, and it's a window of opportunity. Families really bring their newborns to primary care, and they want to know, how am I doing? What did Barry Brazelton tell us? Parents want to know, how's the baby doing? And they also want to know, how am I doing? And I'm sure that resonates for many of you when you took the baby. And did he weigh enough? And was he doing what he was supposed to be doing? And all the checklists that what to expect in the first year, could we check them off? So it's a window of opportunity because it's a heightened time for families. They come and they bring their baby, and often they are the only professionals who have eyes on the baby. So it's a great point of entry. In primary care pediatrics, we know that developmental and behavioral concerns are the new morbidity. We have done a great job in saving children's lives, and now we have to begin to look at a promotive and preventive approach to primary care. Also, that primary care can be a didactic model. A dyadic. I knew that wasn't right when I said it. And I now know it's very wrong. It's really possible in primary care pediatrics to address both the parent and the child. And really the best way to help children is to help their parents. And so at certain levels, pediatric care, and certainly family medicine can be a dyadic model. And pediatricians can't do this alone. They no longer can deal with all of the issues, even that their colleagues are telling them to. You know, you can't get through your electronic medical record unless you've addressed car seat safety, bike helmet control. And yet, the things that parents are bringing are often very different than the concerns that have been listed as guidelines. The other thing about primary care is it's accessible. We've really moved to weekends, same day sick. You can get in to see your pediatrician with your young child. Thanks to the Affordable Care Act, it's universal. And I come from Massachusetts, so we've lived with this model for quite some time. And it's quite wonderful that all children can be seen. The most important part to me is that pediatrics is non-stigmatizing. We are not identifying you're a young parent who may be having trouble. You're a woman in recovery. You're dealing with depression. Everybody goes to the pediatrician. It's what good parents do. And so addressing issues of trauma and mental health within primary care pediatrics is completely non-stigmatizing. There's a high trust factor. How many of you have heard or said, well, my pediatrician said? So unless there's been a real breach, which has happened unfortunately for many families, families come in, they trust their pediatrician. There are no eligibility criteria. And that's really important. And I think when I think about the McVie models, this is a model where we take everyone. You don't have to be a certain age or a certain parity or have a certain condition. We just take, because it's not a referral program, it's a standard of care. So parents take their kids to the pediatrician, and that's where we are. Much like school-based health, which works very well for adolescents, primary care works very well for very young children. This is our logic model, and I think the only thing I'd like to point out is that the upstream factors that we're looking at are not only economic factors, but we're looking at the ACEs, the adverse childhood experiences that parents bring to parenting. We're looking at the notion of the ghosts that parents may bring to parenting based on their own experience, and we're looking at social isolation. So we take all of those into effect and hope to come out the other end with avoiding child abuse and neglect, although that was not the primary purpose of Healthy Steps. So what is Healthy Steps? We add a new person to the pediatric care team, and for lack of anything more creative, we call that person a Healthy Steps specialist. They come with an advanced degree in nursing, child life, early childhood, mental health, social work, child life. And they really provide much of the continuity for families in between visits. They're particularly important and very powerful in residency-based clinics, because they serve as the bridge. Residents have 1/2 day a week that they see families, and if you're trying to get a hold of your doctor, you're not going to have a lot of opportunity if your doctor is a resident, but you can get hold of your Healthy Steps specialist, and he or she can help coordinate the care. We do offer home visits, and that's how we fall into the McVie program. But, and I do want to be very clear here, home visits in Healthy Steps are not mandatory. They are offered, they are encouraged, but they are optional, because our goal is to make sure that parents know how to use primary care, and that primary care becomes their point of contact until they're connected to other services in the community. We do provide developmental screening for kids, and we do look at adult risk factors, both mental health factors and concrete support. So that's where we follow the Strengthening Families model. You know, it's interesting, we all talked about when we started our models 15, 20, 30 years ago, you know, we called it a telephone information line because we used a ground line telephone. Now, of course, we use cell phones, text. Most of our families text. That's how they want to receive information, and that's how we give them information. We do provide an important linkage to community resources, but we are not family navigators, we are not case managers, because we have a relationship with the family and because the family sees both their Healthy Step specialist and their pediatrician at the same time during the well-child visit. So everybody experiences the visit together. We also recommend parent groups, and those can be as diverse as one of our sites has. Of course, now that spring is coming, they're very excited. They're going to start their stroller group again. Bring your baby, bring your stroller. We'll stroll down to the park, and that's our parent group. We also support early literacy through Reach Out and Read. And the home visits are timed to the period of greatest need. There is always the option to schedule more home visits if the family requests it or if the pediatric team has some concerns. We also do spend a lot of time looking at adult risk and protective factors, and in that sense, we found that we were very compatible with the benchmarks that the McV programs needed to address, because we had already been looking at and screening for domestic violence, substance abuse, maternal depression, smoking. We felt really strongly that we needed to address the adult risk factors because children can be powerful motivators for parental change. Many of us in this room might have given up smoking, changed our eating habits, changed our drinking habits when we found out we were going to be parents. So if you can maintain that notion without jeopardizing the parent-child relationship, parents are motivated by wanting to do what's best for their kids. We also think that there's a tremendous risk of underdiagnosing parental mental health, and that it can be done again in this very non-stigmatizing environment of primary care pediatrics. And the third point is the one that's most important to me, is that the act of asking, even if parents don't answer, it identifies you as someone that they might be able to talk about, and the data really supported that. So, how do you become a Healthy Step site? What's the nitty-gritty? Perhaps I was thinking about the readiness checklist that I hadn't really thought about giving a name, but I thought was a great idea. So you got to find a champion. You cannot be a Healthy Step site without being connected in a very contractual way to a pediatric or family medicine practice. The practice or the agency hires the specialists. The specialist, the pediatricians, the residents, and the clinic manager all come to the training. We're really clear that the project manager, the practice manager, the clinic manager, he or she needs to come because she's the person who can make the changes in the EMR that need to happen to really have collaborative care. And so we try to invite as many people from the practice as we possibly can. And there you have the costs of what it means to become a Healthy Step site. I will say that all of our sites are supported by either private foundations or these days by federal programs. We have a fair number of McV and launch sites, as well as tobacco money, First 5 in California, First Things First in Arizona, Children's Trust Fund in Florida. And there's our sites. It's an interesting map. There are clear areas where we don't exist. We're in a number of diverse sites, federally qualified health centers, NICU follow-ups, residency clinics. And our data, which were published in JAMA, were very positive around the outcomes that we had identified with the Commonwealth Fund of really helping families with greater compliance for primary care, making parents feel more satisfied about the care, and also looking at the impact of maternal depression on children. So we found continuity of care, parents did not drop out. And it was very easy to recruit them because when they came in for their primary care visit, they were told, you know, there'll be someone who really is a specialist in child development working with you. And she will be available to answer any questions you have, to make home visits, to see you when the pediatrician doesn't need to see you. And it was a parent who wouldn't want that. So, in fact, in the early days, a lot of my job was getting calls from frantic parents who said, my insurance has changed and we can't go to that practice anymore. My husband's being relocated. Do you have a Healthy Steps practice in Detroit? So we certainly met that outcome, and we did see that parents had greater knowledge of infant development, and to me, the most important thing, better recognition of appropriate discipline. We really found that parents used much less harsh punishment. And harsh punishment was identified as hitting a child with an object other than an open hand. So we were really looking at the extremes of behavior. Unintended consequences, parents reported more child behavior problems to their pediatrician than the control families. We're now looking at adaptations, and again, this is where this morning was so helpful to me. Many rural communities want to use public health nurses who are already on a payroll, who are already doing home visiting. Can they now go to the pediatrician, work with them, not in a casual way, but in a formal contractual way? Can you train them to be Healthy Steps specialists? And we've done that with a number of rural programs. The International Rescue Committee, which brings in families from refugee camps, are using their public health educators as Healthy Steps specialists. It is a platform for additional services, like Fussy Baby. We have also collaborated with Medical Legal Partnership, because if you're going to start addressing concrete supports, you need to have the backup of some legal organization that can help you, particularly around immigration issues. That if the child is a U.S. citizen and the parents are not documented, that child is still eligible for benefits that a lawyer can help you get that a pediatrician really can't. Our pediatricians were very surprised when they were not able to really inform policy by simply writing a note. You know, they could do that for utility shutoff, but they couldn't do that for other housing concerns, and certainly not for benefits. We're looking at delivering Healthy Steps prenatally, also using doulas. There's a Native American tribe that is going to, they want us to train their doulas to be Healthy Steps specialists. And that will also involve cultural adaptations, none of which we being the Healthy Steps office, of which I am the Healthy Steps office. So I also appreciated a lot of the conversation this morning about what it takes to run a program. So we learned that it is a window, it works very well, there's a high trust factor. We were able to deliver the services that we envisioned. And we also learned that pediatricians were a really good agent for validating parents' work. That they could say to parents, you know, you're really doing a great job. Now, their child care provider might be saying that, but it didn't carry the same weight as the pediatrician. In the same way that early childhood folks have been talking about early literacy for, I don't know, 40, 50 years. But when your pediatrician says, it's really important to share books with your baby, and here's a book to take home, look what he's doing with that book. They have a high credibility. So let's capitalize on it. So, dissemination, the great leap of faith. Here's my top 10. We know about a champion. Set a big table. Include everyone in the decision making and acknowledge the work that they've already done. Particularly for us, it was nurses. Nurses wanted to know, isn't that what I do? Yes, and let's add on to what you do and make your job easier by having somebody else. Horizontal and vertical training implications. If I can, I want the bookers, the receptionists at the training, because they're the face of the practice. We touched on this, all politics is local. And so getting a lay of the land, What are the barriers? What are the deal killers for any particular site is important to me. Articulating very clear messages to the recipients of what they can expect, and also for the providers, what they can expect to have happen. Acknowledge unintended outcomes. Celebrate. I know we shouldn't be celebrating with donuts, but that's what they want. And balance your requirements with flexibility. Pediatric practices do not want to be jumping through hoops of fire. They do that all the time. They don't want a new program to make them do that. The challenges, setting the agenda with the family collaboratively. Time. I am here to tell you, if any of you are pediatricians, that we do not impede flow, because that's a big piece of training. Never get in the way of the flow of the practice, because that's the money. Take a look at thinking about, if you're dealing with infant mental health, you've got a kid in the room, be aware that you're opening a can of worms and the child is maybe in the room, and you may have to have a different time to have those conversations. The challenges are HIPAA issues and confidentiality and sharing information. Confidentiality issues, I wish I had answers for you. We do a screen, mom is depressed. Do we write that in the child's medical record? No, because that could be subpoenaed. So there are HIPAA issues, and there are issues around the child is your patient, but the family is your treatment. So that's very tricky. And as I said, we're not patient navigators. Defining what collaborative care means with the pediatrician, that you are sharing the care of the family. And obviously sustainability. For me, the biggest problem is, and again, I appreciate what Lauren said, I do not get any operating costs for dissemination. I am an office of one, and I have no funding for all that administrative support. And in fact, I do not have any administrative support. So the challenge of not having operating costs for the national office, monitoring fidelity as a single-person shop is a problem. And finally, my last point is making sure the right people attend training. The physicians have to sign on, and they have to come. Because if they don't come, it doesn't work. And I think, since my button is flashing, I'll stop there. Oh, I'm very sorry.